Well, I apologize for my introduction. I didn't give Dan very much to work with, so I started saying I got my training at a Holiday Inn because that's where I slept last night. So, and now I'm one of the best, so I'm very excited. But actually, I did train here with the robot. So my medical school is I trained in Iowa, and I am from Michigan, so we came back here for my residency. So the robot was just starting when I was probably my last year residency here. So. My partners were, my senior partner had already been trained on it for a while. My junior partner, he got trained about 6 months to a year before I did. So I'm going to talk about mainly what I do with the robot, and that's hysterectomies. I'm going to show you some slides that Dan put together that he's going to probably add a few pointers that I forget that are kind of important. But as to where we've been with, where we are at with hysterectomies, and where we're going with hysterectomies and the recovery of those. So, what was the first slide? Whoop, did I shut it off? Click it. Okay. So this is from the Journal of Minimally Invasive Gynecology, and basically it's pretty interesting because what it's saying is when hysterectomies are necessary and they demonstrate safety, efficacy, and cost effectiveness of vaginal hysterectomy and laparoscopic hysterectomy, they mandate that the procedure be made a choice to the patient. There are 3 different types of hysterectomies that are being done. Open, where you traditionally get an incision, like a cesarean section incision, from hip bone to hip bone. Laparoscopic hysterectomy with assistance of the sticks, as Dan likes to call them, and then now the robotically. And basically, this is saying if we're gonna be doing hysterectomies, we should be giving our patients the choice to, giving them the option of the different choices to have. And if you're not trained in the robot, then referring them to somebody who is trained in the robot or getting trained in the robot, because that's where we're headed. This slide is very interesting because when the 2 gentlemen, Payne and Dodderuth, is that right? Is that right? They were the gynecologists that first started doing hysterectomies with the Da Vinci. Originally, they were urologists that started doing it, and they're from Baton Rouge, Louisiana, and they do a lot of laparoscopic surgery, hysterectomies. They're probably the gurus of the laparoscopic hysterectomies. The urologists at that hospital weren't using the robots when they bought the robots, and so they thought, well, they'd go to these 2 gentlemen who do a lot of laparoscopic surgery to see if it was a possibility that they could start doing hysterectomies with them. And what they found was, they agreed to do the study. They found was, this slide shows the overall total abdominal hysterectomy rate, pre-robotic, with the Da Vinci and the last Da Vinci. So what does that mean? Whenever we board a hysterectomy for laparoscopic or robotically, we always need to board it for possible open, just in case there's complications, blood loss, trouble with, you need to get in and get your hands on. So before the Da Vinci, they have a 1 out of 4 rate of going open. A lot of times open goes because of previous surgeries. Patient had 5 C-sections or 3 C-sections or had their appendix out and have scar tissue. So once they get in with the laparoscopic equipment, they can't see, so they would convert to open. After they did the first 100 Da Vinci, it was down to 4% that they went to open. The very last 25 of the Da Vinci, none. They didn't have to go to any opens. They had perfected their skills so well that they did not have to convert from a laparoscopic to an open hysterectomy. Do what? Oh, because it highlights those. Okay. So this slide shows kind of like the curves that he was talking about, the gynecologists that are getting trained, and in the year, the number of gynecology, how many professionals across the United States were actually getting trained. And you can see in 2010, from 2004, there were 11 gynecologists trained in robotic training. By 2010, there's almost 1,500 gynecologists being trained. And again, this slide shows laparoscopically, the low laparoscopic surgery is hard. Like Dan said, it's opposite of what you think it is. So you're going in and you're using your hands and you're going rights, right, lefts, lefts, trying to get things out of the way so that you can see. You can see when the curve for the Da Vinci, the curve to learn it and be able to use it was exponentially much higher than the laparoscopic across. Indications. All right. So most of you guys are primary care, internists. You send a lot of your patients to us for bleeding. That's probably our biggest referral basis for bleeding, ongoing bleeding that doesn't stop. So the Da Vinci surgery for gynecology also works for other procedures, laparoscopic oophorectomies. But we're going to talk about why this is this procedure is so much better for the patient. And let's see. We also did them for cancer. So as a gynecologist, we trained in for 5 years. But if we want to do a fellowship, that's another 3 years. So those are gyn-oncs. So the gyn-oncologist, well, if we discover cancer, they'll do the hysterectomy. Or if we've already done the hysterectomy, they'll come in and do the staging. What's nice is they can use the same ports to go in and stage these women, where before, with any kind of gynecological cancer, it wasn't a nice little incision from hip bone to hip bone. It was from chest bone all the way down. They were up and down, so they could get lymph nodes and get everything they needed. So these women had horrible scars from those. And conventionally, it was not widely accepted, because when you're going after lymph nodes, you're having to go way deep inside the pelvis and go behind major vessels to find lymph nodes, because we're not just checking one area lymph nodes, we're checking 5 different area lymph nodes. Endometrial cancer, same thing, very difficult to do. Another difficulty was if you had a very obese woman. And unfortunately, when we see a lot of the endometrial cancers, it is on obese women because they have the higher levels of estrogen. So very difficult doing an open staging case on these women, and the comorbidity was just unbelievable because of their health. And what I do most of them for, if I find cancer, I refer them on. What I do most of mine for are vaginal or uterine prolapses. Those are the other reasons that we do them, other than just the heavy bleeding for the postmenopausal women whose uteruses are coming out. When we do them vaginally or laparoscopically, you're tying, you're not directly tying, or you feel that knot going down, stitching it. So you're always tying, but you don't know how tight it is or how secure it is. With the robot, you get that feeling from that because of the manipulation of the hands. Endometriosis, scarring from stage 4 endometriosis. Most of these women were open for surgery because it was a frozen pelvis where nothing moves in the pelvis. So we're able to manipulate around things with the robot that we weren't before. These women always had opens. They weren't given a choice. And fibroids, which is usually the biggest cause of bleeding, miscarriages, things like that. We're able to remove fibroids for women, called myomectomies, for women who have not had their children yet. And then we're able to remove these with the robot, which is phenomenal. My largest uterus was about a 24-week size uterus. So 24 weeks pregnant, that's her uterus was up just about to her xiphoid process. We were able to do this robotically by cutting that uterus into 9 pieces to get it out the vagina with 4 little incisions with less than 50 cc's of blood loss, going home within 24 hours of her stay. And it makes it much, much easier on these obese women to be able to recover better and quicker. And some of the benefits. Obviously, incision size. You know, Dan talked about, you know, how women like to have very small scars, and they're all about trying to prevent as much as they can as far as showing their abdomens off. So open surgery always is a long, big incision. With the Da Vinci, the incision is less than 5 millimeters, and technically we don't even need to put a suture in them. I do, just because most women like to get back to exercising, get back to doing what their daily life. So I have a little bit more confidence by putting that little stitch in there, but it's not even necessary. Discomfort, you know, with any abdominal hysterectomy or laparoscopic hysterectomy, the average woman is given 4 to 6 weeks off of work for recovery time. I have women going back to work in 2 weeks. I've had women go back in 4 days. For these women who are the money winners, who can't take that much time off work, who can't afford that much time off work, they're going back to work in 2 weeks with these incisions. The recovery is just like any other laparoscopic surgery. So if you have a gallbladder or appendix, what most women complain about or feel will be that gas absorbing. That's their biggest complaint, that 2 or 3 hours where they feel like they have chest pain or an elephant on their shoulder. Once they get up and walking around, that goes away. Hospital stay, open surgery 3 to 5 days. The Da Vinci, my gals are home in less than 23 hours. Only once have I had to keep one over longer, and it was just because she had a lot of other comorbidities. But from the standpoint of the surgery, she could have went, but we were trying to get her other things under control. Recovery, 1 to 3 weeks. It's just like night and day. These women, and we already talked about turning back to work. So just a little bit about fibroids. They're benign growths of the uterus. They cause the uterus to grow. They get blood vessels that feed them. So every month when they get their period, these blood vessels grow and make the uterus larger and larger. Fibroids can be on the inside of the uterus, on the outside, throughout the muscle. When you're treating fibroids, you can treat them conservatively, start them on a birth control pill. A lot of women can't have birth control pills. They're smokers over 35. You can do, the FDA has approved the Mirena IUD, but that is an intrauterine device, and a lot of women don't want things inside of their uterus. Minimally invasive surgeries are like endometrial ablations, which are very nice if their uterus is small enough. Unfortunately, most of the time when women are coming for their bleeding, their uteruses are 10, 15, 20 week size. So ablations don't work on uteruses that big. It's also important to think there are 4 or 5 different ways to treat heavy bleeding, but the only definitive way is a hysterectomy. You can try all those other things, and a lot of insurances are requiring us to try a lot of those things now, but the only definitive way to stop their bleeding is with a hysterectomy. So if you're going to do a hysterectomy, these patients should be offered all forms of it so that they can make the informed decision to do which type they want to do. With the Da Vinci, less blood loss. Dan makes fun of me because he says I yell if I have more than 50 cc's. Well, I don't ever yell, but when they are saying there's 100 cc's, I'm like, no, let's pour it in a cup and see, because But it is amazing that you can do these procedures and have less blood loss than you do from the anesthesiologist putting the IV in. So less blood loss, fewer complications. My gals don't get, when they come out of surgery, they're not put on a PCA pump because they don't have the pain they would have with the other surgeries. Then therefore they don't have the nausea from the PCA pump. If they have pain, we give them a little pain medicine in the IV, but by nighttime they already have their Foleys out and they're already getting to eat. Scarring, we talked about, shorter hospital stay. Some insurances are requiring that they are not allowed to stay, so that's why we've just gone to a 23-hour OBV, and then if we feel the need, we extend their stay. Lower conversion rate to open surgery. I've done, I think Dan said 152. I've not had to open one patient. And I think we talked about some of these things. These are just the pictures. This is the typical what someone gets when they have cancer, up and down. I only use, you can use all these ports. I only use 4 ports, 1 in the middle, 2 on the left, and 1 on the right. If you can use more, there are more arms to the robot for women who've had 5 cesarean sections or multiple abdominal surgeries, so that you can better move things around so you can visualize better. It's becoming the most effective, least invasive surgical option. The one thing Dan didn't mention is that we have the state-of-the-art robots, but we have the only dual console. He might have mentioned it, but we have the only dual console in the state of Michigan. So our residents are sitting right next to us now. It's very difficult to give control to a resident when you're looking in and you can't look in while they're looking in. With the dual console, they have 2 robotic hands. If they're getting close to anywhere they shouldn't be, we step on a pedal and their hands are frozen. And then on our hands, we have little arrows, so we can just draw right where we want them to cut, or we can say, what is this anatomy? Why do you not want to cut through that? Those sort of things. So our surgeons are going to come out trained better than any other residents in the state of Michigan. So that's pretty exciting. Yeah. So you all know who to consult if you have any GYN issues. So, all right, that's me.